Hi, my name is Pablo Martinez, and today I would like to talk to you about the recent advances in migraine treatment. For today's presentation, I would like to do a quick recap on the topic of the definition and classification of migraines, and later I will focus on what do we have to treat migraines and the new treatments coming up. To start, I want to bring to your attention this fairly generic case of a 40-year-old female patient who, even though she has tried multiple medications, she has yet to find a treatment that allows her to lower both the frequency and intensity of her migraines. Now, this case often happens at the neurology office because while people do find immediate treatment for the acute episodes, they still happen at a bothersome rate. So, part of the job of the neurologist is to find a long term treatment. Now, let us not forget that migraine remains the sixth most common disability in the world. Especially in the US, up to 44.5 million people are affected by this disease, and it is often diagnosed in middle aged people. In order to diagnose a migraine, we need to use the criteria set by the Third International Classification of Headache Disorders. While we have many different types of migraines set by this criteria, most of the migraine cases tend to fall within these two categories: the migraine with aura and the migraine without aura. For the migraine without aura, patients need to present with headache attacks that last from 4 to 72 hours when untreated or unsuccessfully treated. The headache needs to comply with 2 out of 4 specific characteristics. It could happen in a unilateral location, be of pulsating quality, cause moderate or severe pain, and can be aggravated by or cause avoidance of routine physical activity. The most common type of aura is the visual one, which occurs in over 90% of patients that experience a migraine aura. It is unclear, however, whether the physiologic alterations that give rise to the aura have a propensity for the visual cortex over other cortical regions, or are simply more recognized. To formally diagnose a migraine with aura, the headache must comply with 3 out of these 6 characteristics. At least one aura symptom that spreads gradually over 5 minutes or more, 2 or more symptoms in succession, symptoms lasting from 5 to 60 minutes, one unilateral aura symptom, one positive aura symptom, or that the aura happens at the same time as the headache or within the previous 60 minutes. Over time, clinicians have developed several screening tools to rule out, identify, and diagnose migraines. Some examples are the headache diary, headache calendars, the ID migraine questionnaire, and the migraine screen questionnaire. There's also the POUND mnemonic, which enlists some of the most defining features of a migraine. A score of 24 represents the likelihood ratio of 24 of having a migraine. When talking about migraines, we tend to forget the full migraine episodes. Not only does it encompass the headache phase, but also the prodrome, the aura, and the postdrome, all of which may also present with disabling symptoms. If we take into consideration all phases, a migraine attack may last up to 7 days. Needless to say, a migraine attack can heavily impact a person's life and should be treated promptly. Now, what kind of therapies do we have for treating migraines? When choosing the right approach to treat a migraine, we must consider several factors relating to the patient and its way of life. Things such as the avoidance of triggers, the healthy coping mechanisms, and patient symptoms may guide us into choose the right therapy for this patient. However, we must also consider the patient's preferences and the medication effectiveness before we choose the appropriate treatment. And finally, the lifestyle modifications of the patient are really important because they will guide us into choosing the best treatment for the patient. When speaking of pharmacologic treatment, a number of medications have been effective at various degrees. Some of these medications, such as the NSAIDs or analgesics, may be found over the counter. Meanwhile, other medications are reserved for refractory or complicated cases, such as antidepressants. Other medications, although they do not have a direct effect on a headache, they do reduce other associated symptoms. Basically, there are 2 types of different migraine treatments. There's the acute treatment and there's the maintenance treatment. The acute treatment, also known as abortive treatment, treats the episodes when the patient is experiencing a migraine attack. It must be emphasized that the acute treatment does not have an impact on further attacks. Most of the acute medications are taken by mouth. However, a select group may be given as an injection. The current standard of treatment of migraines uses a step-based approach, where patients start with the most common treatments and go up a step every time they experience 3 consecutive attacks under the medication without success. Patients may also benefit from using prokinetic agents to avoid the nausea and vomiting when experiencing a migraine attack. After NSAIDs fail as an abortive treatment, clinicians resort to triptans. They are selective 5-HT1B1D agents that allow vessels to constrict and the release of vasoactive peptides. Studies show that triptans relieve headaches within 2 hours in 43 to 76% of patients. In addition, 18 to 50% of patients experience freedom from pain within 2 hours. When talking about sustained relief, triptans provided sustained headache relief at 24 hours in 29 to 50% of patients and sustained freedom from pain at 24 hours in 18 to 33% of patients. As for the preventive medications or maintenance medications, they are usually created to be taken at a periodic dose, such as daily, weekly, or monthly. They may play an important part in controlling migraine, but the idea of giving a long-term therapy that requires a conscious effort by the patient must be weighted against the patient's preferences. Now, just like in abortive medications, the preventive treatment also follows a step-based approach. In the first line of treatment, we have the beta blockers, topiramate and candesartan, an angiotensin receptor blocker. Then we go up to the second line of treatment, which includes flunarizine, amitriptyline, and sodium valproate. And finally, if that doesn't work in 3 cases or more, we go to the CGRP monoclonal antibodies. Now, I would like to focus more on the topiramate because since the 2000s, we know that topiramate works as a preventive medication, and it makes an important effect on both scales, the SGIC, the subject's global impression of change, and the PGIC, the physician's global impression of change. We do not exactly know the way topiramate works in preventing migraine. However, we do have some theories, including the negative effect on the AMPA receptor and the positive effect on the GABA A receptor. Now, when the patient doesn't respond to the first or second line of treatment in the abortive or the preventive medications, then we go on to molecules that modulate the CGRP. Now, CGRP stands for the calcitonin gene-related peptide, which is a 37 amino acidic peptide chain that is expressed in the central and the peripheral nervous system. It is released after the trigeminal nucleus stimulation, and there are several receptor expression sites like the intracranial vessels, hypothalamus, and the parabrachial nucleus. And this peptide is involved in the development of migraines and cluster headaches. Now, as we can see, this is a picture of the many different sites where the CGRP works, and this includes the spinal trigeminal nucleus, the sensory afferents, the trigeminal ganglion, the vascular smooth muscle cells, and the meningeal blood vessels. The first CGRP inhibitors never made it to the phase 3 and 4 studies, but the newer versions of these medications have really proven successful. We have 2 different effective oral antagonists. There's the ubrogepant, also known as Ubrelvy, and the rimegepant, also known as Nurtec. So for the ubrogepant, thanks to the Achieve 1 and 2 studies, we now know that Ubrelvy works best using the 50 or 100 milligram dose. However, in total, 200 milligrams can be taken every 24 hours. They have proven that this medication did help to achieve a sustained freedom from pain and help to relieve pain after a 2-hour period. The most common side effects were the nausea, the vomiting, and the dry mouth. Now, rimegepant, which is sold as a 75 milligram disintegrating tablet, 4 different phase 3 studies have analyzed this drug, and the results have been pretty promising. The first 3 studied the use of this medication as an abortive treatment, and a 4th study, carried out in 2021, studied its use as a preventive medication when taken daily. The 4 studies showed positive results, and this means that we can use this medication either as an avoidant medication or as a preventive medication. So as we can see in this chart, this is a summary of the 6 studies that analyze the effect of CGRP inhibitors, and all 6 studies show a significant difference in freedom from pain after 2 hours when comparing the drug to placebo. Most of these studies, aside from freedom from pain, also compared the difference of the most bothersome symptom, with promising results. And another form of modulating CGRP can be done through monoclonal antibodies. Currently, there are 4 different types. The first 3, fremanezumab, galcanezumab, and eptinezumab, are antibodies against the CGRP peptide. And the last one, erenumab, works against the CGRP receptor. As with other monoclonal antibodies that work in other parts of the body, these monoclonal antibodies can be given in an IV infusion or as a subcutaneous injection. They have little to no adverse effects, and they are metabolized by the reticular endothelial system. So all 4 monoclonal antibodies have been tested against placebo, and they all have shown a statistically significant response at different cutoff points. Most of these studies tend to use a 50% response as the main cutoff point, and this is a place where we have seen the strongest evidence for the monoclonal antibodies. One of the ways we measured the effectiveness of the monoclonal antibodies was by measuring the number of migraine days experienced per month and the number of migraine days that required antibiotic treatment. And as we can see in all 4 of these studies, when we compared the monoclonal antibodies against placebo, we saw that they all showed a significant difference. And also, as a qualitative way of addressing the effect of these medications in the patients, we measured the MSQ, the Migraine Screen Questionnaire, and we saw also a statistically significant difference. Also, a remarkable fact about these medications is that the response from the monoclonal antibodies tends to go higher every month of treatment use. They are also very safe to use since little to no adverse effects regarding allergic reactions against the antibodies by anti-antibodies were recorded. Since these treatments are fairly new, we have yet to see them incorporated into the recommendations and guidelines for migraines. One of the associations that first endorsed the use of CGRP antibodies was the European Headache Federation, which stated that the antibodies may be included as a first line of treatment, but more information is needed to understand its effectiveness when combined with other types of medication. We still reserve the CGRP antibodies and the CGRP modulators overall for patients who do not respond to the classic abortive and maintenance treatments, because while they work very well in complicated cases, 40% of patients do not respond to these drugs. So only when drugs with a higher level of responsiveness have been tested and failed, we may use these treatments. Another new medication type that was recently approved for migraines was the 5-HT1F receptor agonist. We only have one medication from this family, which is lasmiditan. So lasmiditan, as well as the whole family of the 5-HT1F agonist, was created as a response to people who do not respond well to triptans or who cannot use triptans because they have some sort of cardiovascular disease that doesn't allow them to use this medication. And one of the interesting facts about this medication is that it blocks the release of CGRP. There are 3 different presentations, the 50 milligram, the 100 milligram, and the 200 milligram dose. However, we have seen more effects with the 200 milligram dose. There are 3 different phase 3 studies that have studied the use of lasmiditan. There's the Samurai study, the Spartan study, and the Centurion study. And it has worked pretty well. However, there is a specific side effect that must be noted. That is that this lasmiditan creates dizziness, impaired balance, somnolence, fatigue, and sedation. And it shouldn't be used for people who drive or who operate heavy machinery. Now, this is a chart taken from one of the phase 3 RCTs that studied lasmiditan. And as we can see here, there's a statistically significant difference for the use of lasmiditan regarding somnolence, fatigue, and other side effects. That's the reason we do not use this medication in people who drive or who operate heavy machinery. And this is a result of another interesting study, which showed sort of backs up the information I mentioned previously, that the use of triptans are generally more effective for treating migraines than the newer medications. That is the reason we reserve lasmiditan and the use of CGRP inhibitors for people who do not respond for the first lines of treatment. And finally, let's talk about some of the newer treatments for migraines. One of the treatments that has shown promising results is the use of the botulinum toxin, most commonly known as Botox. For many years, Botox was used as an off-label medication for treating migraines, but after 2010, when the results of the PREEMPT and PREEMPT2 trials were released, the FDA approved the use of this medication for migraines. Botox can be injected in 39 different places, especially in the frontal and the occipital regions of the scalp. This is an especially effective treatment for patients with chronic migraines. We also have interesting non-pharmacological treatments. One of these is the non-invasive vagus nerve stimulator, which blocks some of the nociceptors and decreases the firing of the trigeminal neurons. There is also the electric trigeminal nerve stimulator, which works on the supraorbital branch, and it prevents migraine attacks as well as it treats acute migraine cases because it inhibits the trigeminal pathway. Also, as non-pharmacological treatments, there's the remote electrical neuromodulator, which works both as an acute and preventive treatment. It works by using this device for 45 minutes per session, and it creates some sort of conditioning of the response to pain. There's also the single pulse transcranial magnetic stimulator, which inhibits the cortical spreading depression. That is the same pathway that creates the auras. Now, finally, there's the PACAP, which stands for the pituitary adenylate cyclase activating peptide, which is a 27 or 38 amino acidic peptide and is homologous to the VIP peptide. It is released by the impulses of histamine and serotonin, and it works in the neuroinflammation and vasodilation. And this is interesting because the CGRP and the PACAP share many similar intracellular pathways, and the places where we can see more expression and receptors of the CGRP are the places where we also see the PACAP activity. Now, there are two promising RCTs coming up, and the results that we will see in these two studies will determine whether or not we can use this medication in the future. So, as a way to conclude this presentation, I would like to focus on these key points. First, we can see that migraines remain one of the most common and most disabling conditions in neurology, that we have several medications to treat migraines, that we need to make sure that we are choosing the appropriate treatment according to the patient's diagnosis, the comorbidities, the lifestyle, and the patient's expectations. That many patients do not respond to the first or the second line medications. Also, as a way to conclude, we can see that CGRP blockers have proven successful for treating acute migraines, that CGRP monoclonal antibodies can be used as an effective maintenance treatment for a select number of patients, that Botox injections may work for people with chronic migraines, and the new non-pharmacological treatments may help to reduce the disability in patients who still present with headaches. Thank you very much.